as we are walking you through the different health system building blocks, we have reached one of the major ones, and that's the money. It is time to talk about financing and how to finance a health system that is fit for purpose and yet ensures that people living with cardiovascular disease can access the services they need without incurring financial hardship. It is my pleasure to invite Dr. Payal Kohli on the stage. He'll be the moderator for the next session. Dr. Kohli is Associate Clinical Professor of Medicine at University of Colorado School and founder of Cherry Creek Heart. Payal, over to you. And we're matching.
Good afternoon, everyone. What a pleasure it is to be here. And yes, we did coordinate to match and in the hot pink. So just to tell you a little bit about myself, I'm a general preventive cardiologist from Denver, Colorado, own and run my own private practice. I'm also an associate adjunct professor at Duke University and Johns Hopkins University. And I work on television to teach people in the United States about the importance of health, because we've been talking about patient education, patient empowerment, and knowledge is power. So I'm really excited today to talk to you about what I think is probably the most thrilling session of the day, which is a talk about money. So before we set up the session, I'd like to invite all the panelists on stage. So I'll start with Dr. John Harold, past president of the American College of Cardiology, professor of medicine at Cedars-Sinai and UCLA. Thank you, John. Next, Dr. Francisco Lopez Jimenez, professor of medicine at the Mayo Clinic, chair in the Division of Preventive Cardiology. Maybe he took a late lunch. Ms. Hyvell Ferguson Davis, founder of Heart Sistas and a patient advocate, here to give us the patient perspective. Dr. Lillian Mabau, World Heart Federation Advocacy Committee member and CEO of the Kenya Cardiac Society, and also preventive cardiologist. Dr. Joe Kutzin, former head of health financing policy at the WHO, and a health economist, which we're lucky to have a financial perspective, over 35 years of experience in Africa, Asia, the Caribbean, Europe, and the United States. And last but not least, our pace-setter lecturer, Dr. Bente Mikkelsen, who is the Director of Global Engagement Strategies at St. Jude's Children's Research Hospital. She is a gynecologist and obstetrician by training, has a master's degree in health administration, and is from University of Oslo, Norway. Over 20 years of senior management experience with WHO and other organizations. So before I start, I want to ask the audience a question. Raise your hand if you don't feel that money is important to your life. Any hands in the audience? No, because I don't think there's a single individual. Oh, I saw one half a hand. Money makes the world go around, right? And there's not a single individual out there that doesn't think about money and how it enables them to live the type of life that they want. Perhaps a threshold effect, perhaps there's an inflection point, what have you. But money is important. And without thinking about money in medicine, we cannot change cardiovascular disease. So I think that really sets us up nicely for this session, which is the financial protection from the catastrophic costs of cardiovascular disease, and what does it take to reduce this by 50%. And if you think about it, the concept is really provocative, right? Because we spend a lot of time talking about science, about advocacy, about healthcare delivery. But what is often the barrier? The money, the cost. The patients can't afford their medications. It costs the healthcare system too much to prioritize prevention. So what ends up happening is that cardiovascular disease isn't just the #1 killer, it's the most preventable source of economic loss. Now, everybody here has a credit card, right? And what do they teach you about being wealthy? You don't borrow money on your credit card. So if you borrow $1 today on your credit card, in a few years, it'll be a few $1,000s of debt. And in a few decades, it'll be tens of thousands, if not millions, in debt. The United States has an economic burden of $400 billion from cardiovascular disease, direct and indirect, due to lost productivity. Imagine if you borrowed $400 billion on your credit card. It doesn't just impact today, it impacts tomorrow and the generations to come. So with that being said, and knowing that it isn't just heart disease, it's diabetes, it's obesity, it's hypertension, it's inflammation, it's all the things that have an impact. We're going to talk today about how the economic impact bears out, and most importantly, what we can do, policy solutions, clinical solutions to change this. Because as I said before, without thinking about money, we can't change heart disease. So with that introduction, I'd like to invite Dr. Bente Mikkelsen up to give our pace-setter lecture to help us understand a little bit better about this economic burden.
Should I start? Yeah.
Yes, please.
Thank you very much. Thank you very much. And I think I can start with saying that there is no quick fix. So I would like to start again a little bit with the magnitude. We have heard these figures all day, and I think most of you know that we are talking about 40% of the deaths in the world, that we are not reaching the SDGs if we continue like this and so on. But I think we need to dig a little bit deeper because it's even worse. And I want you to do this because whatever we say today on the actions, it has to happen quick. So just this week we had the World Health Statistics Report 2025 revealing a lot of new statistics from WHO. And you saw the figure early this morning on how life expectancy fell in the US, but actually globally it fell by 1.8 years. And most of the reason is, according to this report, COVID-19. And actually, the reduction in global health life expectancy by 6 weeks that we saw due to mental health and anxiety absolutely is the closing, I would say, is erasing most of the gains that was made from lower mortality due to non-communicable diseases and the risk factors during the same period. So during this period, we lost a lot of traction. We lost many lives, but we also actually lost the progress that was made before. So it's a very vulnerable situation with big figures. And I want to sort of make the figures even a little bit bigger or the picture a little bit more dire, because we need to take into account that the number of people dying from NCD and injury-related conditions will increase by 1 to 2% per year, and this is because of population growth and aging. So again, this will double deaths globally and lead to much greater need for health care by 2050. So for those politicians that look at these figures with complacency, I think they need to wake up. Because we have a tendency to think everything is sort of linear, everything is sort of on track or at least not happening, and we have to sort of speed up. I think we have to double up. And there is one more challenge that hasn't been mentioned too much today, and which I have used a lot of time for on the last years, and that is to focus on the real vulnerable part of the population. And that is the 2 billion people that live in fragile, conflict-affected and vulnerable settings. And this includes 468 million children. And just think about it. Many of these people in forced displacement, they live 10 years internally displaced and 20 years as refugees. And I just went to Emro, and it's not a surprise, but if we look into the risk of dying from NCD in Emro is 17.8%, but among these forcibly displaced persons, it's 25.1%. So again, this is big numbers. And the last one of this, about the magnitude, is that this will increase also by another reason. And that is, we have an estimate of 1.2 billion people that will probably need to displace because of climate change and natural disasters by 2050. So only this very vulnerable population will suddenly have the numbers of 3.5 billion, and with an even higher risk of NCD and mental health included than we had before. I wanted to mention these figures because we need to have it as a backdrop. Of course, the opportunities, we have spent some time on this as well, because if we want to find a way to finance, we really need to understand what we can do to reduce the need and to try to make this something that we can cope. So of course, the most important is to apply the best buys, cost-effective interventions. And we have seen from the Lancet Commission that it is possible to reduce the premature mortality with 50% before 2050. Of course, it's estimates. If we use cost-effective interventions, if we really invest in new technology using innovative financing mechanisms for some specific things like shaping markets and on essential drugs and supplies, and use the cost-effective interventions. So there is a mean also on the big sort of global public health perspective to reduce the big magnitude that we were talking about. And this is a huge job. If we then move to financing, I think we need to acknowledge that a lot of money is actually spent on NCD and mental health. Usually we speak as if it's not, but it is. When we look at the countries that have an absurd growth in total health expenditure allocated to NCD and mental health, it is a little bit of promising if you look at the curves, but when you then look at the sources, unfortunately a lot of this money comes from out-of-pocket. So meaning that people are trying to, they use their own savings, and they try of course to find services, they want to save life, they want to treat. And the way they very often do this is, because they need, move to private sector suppliers in countries where the public health system cannot cover their needs. And we also see that most of the out-of-pocket expenditure is towards medicines in most countries. So we know what the out-of-pocket expenditure is used for, and that is also a way to address it. So I think so far we know that if a person could have been diagnosed earlier, had access to prevention methods, had regular care, their life would be much longer and their health care would be cheaper. So another way of saying this is if we had financial protection, if we had public financing of NCD prevention and care, that is the way to save life and money, and it's far more equitable than continued private financing. So this brings us back to when we discuss financing, we again have to discuss how the public health system and the decision made by the politicians. There is no escape actually. Every other system seems to be, at least so far, the more expensive one. I think it was mentioned earlier today that things have gotten even worse on the financial side. There is a lot of competitions. We have seen now many countries are shifting from health budgets to military expenditures and prevention measures. And we see also that this implicates global public health. We have seen the decrease in ODA, less commitments, and of course we know that because of decisions in the US, it was an absolutely abrupt and very, very dramatic change in many low and middle income countries, and for more or less whole of the global public health community. As you will talk, I think, all week long here in Geneva. We have colleagues in almost all organizations that are now downsizing. And of course, the first effect on UNAIDS, we have figures on down to the level of the patients. So what was big priority problems before has been even bigger. So this is a very dark picture. Is there any hope and any solutions? So WHO, while I was there, we had two meetings on NCD and financing. And why did we talk about it? I think when I started at WHO 12 years ago, many people wanted to have an NCD global fund. They wanted to have a cardiovascular global fund or a cancer global fund. There were some ideas that we could imitate what had happened during the MGGs and that we would have our own sort of funding source like malaria, TB, and HIV. I think quite quickly everybody agreed that this was not the way to go, and there were no political interests to imitate. So then the second way to go was to try to change a little bit the mission and actually act on the science, namely, and we discussed this earlier today, that for example, an HIV patient, female HIV patient, has 6 times more risk to develop cervical cancer than a non-HIV patient. So if the Global Fund really want to save women with HIV, they should also fund comorbidities like for cervical cancer. And all of the HIV patients had a tendency to have comorbidities within cardiovascular diseases, of course. But this was a very big challenge, and I think when I left, we had to manage to have 21 proposals agreed. So of course, this is something that needs to be developed. So the reality of the fact, and maybe Joe completely will shoot me down now, but I don't know. He said, don't expect me to agree with you. But anyway, the reality is that the whole financial structure has to be changed, not only because of the USA as a donor, but because the world and the demographic has changed. But I think whatever we think about, it is clear that it is a need to shift to domestic financing for NCDs and for cardiovascular diseases. So the second meeting we had on NCD and financing, the first one was with the government of Denmark in 2018, and the second was between WHO and the World Bank in 2023. So some of the things I will speak to now is coming from these meetings. So meaning that when I come to the conclusions, you will understand that this is conclusions not sort of coming from me, but coming from so many experts, working groups, scientific papers, people really trying to find, is there any panacea? Is there any sort of silver bullet that we didn't think of before? And I can already disclose it's not. So it's only hard work. But let's go to the first one, which is a very optimistic one. And we talk about this, and even now you have seen that the World Heart Federation is very clear. We want to increase the taxation, 50% excise tax on products like tobacco, alcohol, sugar-sweetened beverages. And we say that, it seems like a simple thing to say. But we have other health economists, like a dear friend called Rachel Nugent, and she has been working on this, and I'm quoting something that she was mentioning in a hearing, which was part of the preparatory process for the high-level meeting as well. And what she referred to was studies on 36-country tobacco investment cases. And I just want to mention a couple of examples to make it a little bit real for us. So they found that countries lose from 1 to 3% of GDP annually due to the socioeconomic cost of tobacco use. So that is health expenditures and loss of productivity and lives. So if we look at Ghana, has very low tobacco use and very low economic cost. On the other hand, she said, Georgia experienced 2.5% GDP loss annually from tobacco use. So if we focus on Georgia, if 4 tobacco control policies are implemented, over 15 years tobacco use prevalence will be almost cut in half, 53,000 lives saved, and 1.5 billion in socioeconomic cost avoided. And the return of investment in this case is 364, meaning $364 in benefit per dollar in cost of implementation. That's quite something. And it's even healthy. So this is a way to do it. But is it easy? So from the same study, she draws some lessons, and that was, if we want to go down the route of taxation, which is not a question at all, we have to, then the importance is to do it in the context of the country. And I think this has been some of, not the wrongdoings, but maybe the naivety in the first 10 years since the first political declaration. And maybe we couldn't do anything else either. So we worked very much on the global level and tried to sort of define things that seems to be possible for all countries. But of course, no surprise, to analyze the country context was extremely important. And then the collective actions on taxation is powerful, allowing countries to learn from each other. So bringing them together when they are including their new taxation laws and trying to learn down to collecting the revenue. I think the new decade will be a decade of granularity. I don't think we can continue, and the good thing is, and this is part of my optimism, is that I see that at the regional level, in all the kind of regional platforms that we have from in the African countries or European Commission, all the different PAHO, we have many different, or the CARICOM, all the SIDS countries. There is a willingness to come together in similar countries and do things together, also search for cross-country solutions, and of course with the aim of support at the country level. And then, of course, we all know that even if we have taxation law and everything seems to be very well planned, there is always somebody that actually gets a little bit more than they expected, and mostly they get less. And this, she says, is also about how well the tax is designed, implemented, and especially enforced. So that was an example of good news. We know about it, but we cannot only talk about taxation like that. I think even an organization like the World Heart Federation, we need to understand this down to more granularity and to at least be able to help countries to express demand when it comes to taxation. So I want to touch on the ODA. As I was mentioning, the development assistance has now unfortunately gone down, not only from the US, but also from countries like my own, the Norwegian government, the Danish government, and so on. And it is because they feel threatened. It is a completely new situation. And when we analyzed some of these things before the last meeting on financing, we found that it has only been one golden age on this. It was from 2000 to 2009, and then we saw a deceleration in 10 to 19, and then it was a little bit higher during COVID, but that didn't really benefit NCDs, as you know. So if we consider that the level we have today, what should we use that money for? Because even if we say domestic, and this is not coming from me, this was coming from, I think we had like 30 countries in the meeting with the World Bank. Some countries will need international funding. We cannot just say they don't. Some countries will need catalytic funding, but it's maybe the way we do it. And also maybe, and this was discussed during the meeting, maybe we could use this for something different. Maybe there are some public goods that could be developed. Like when I worked in Euro, there were a discussion and even an implementation of standard tobacco taxation laws in the CIS countries, which are quite similar. Could we use it for more cross-border issues, or maybe to strengthen leadership and stewardship? And if we are going to continue, and we have to use it for country level, it should be more towards some principles. And we discussed during these conferences what kind of principles could this be. And one of the things that come very strongly was that if it's catalytic, it should be truly catalytic. So it should actually be sustaining or supporting gaps for highly cost-effective intervention and programs. So it should be more sort of used for where we really are able to see the effects. But of course, that should not be defined by any of us. It should be defined at the country level. Also, to develop standards. I mean, most of you have been in these kind of settings, and it's totally amazing how all kind of donors with catalytic funding have their own system, their own sort of formats. I mean, people are using more time many times on this than what they can do after they receive the small pockets of money. So standardization of approaches is very important. And also this, everything was about one size does not fit all. And also the discussion was, could some of the ODA be used for NCD in humanitarian setting, which most of you know have been almost neglected. And of course, I think most agreed as well that there are really poor countries that still will need international funding for many years to come, what to do about them. And not all of them are even categorized as the most poor countries. If we look at some of the SID countries, they are actually middle-income countries, but the vulnerability in those countries are so high and they are so small that even to establish stewardship or actually a good governance is very, very difficult. I will not go into the discussion about private-public partnership and new funding sources, but I think we need to, of course, continue what I can see happened very, very much during COVID, is that we will do, but I don't call this funding. This is partnership and collaboration. So there must be opportunities for even social impact models and all this, but I think we should stop calling it innovative funding. I think Dr. Slim Slama mentioned the same, and he has a hat on now from Qatar Foundation. I think we need to think differently. There is one funding in a country. It should be with the Prime Minister or the head of state and with the Minister of Finance. And if we are so lucky to find ways through the European Investment Bank or others or foundations, it should be part of the budget. So I will, you're probably now very disappointed, so where is the silver bullet? No, it's not any silver bullet. Of course, I think we haven't discussed, and I hope you will do that, Joe. There are also ways in NCD, as in other sort of areas of public sector and public health, to reduce waste. So strategic procurement, really think about how we use the money, is also a big challenge. So if I should summarize, first of all, we cannot wait. Nothing will happen if we wait. The development will just accelerate and get worse. Secondly, we need to integrate NCD and health and mental health into overall public health financing system. It's not a separate system, it is part of the system. So this approach is important because then we are able to look into financing functions and mechanisms, and also, as I mentioned, strategic purchasing, financial protection policies and measures, and financial management, as we do for all health and also other public health, all the global public health and national public health system. So the third conclusion was domestic financing is at the heart of sustainable financing for NCD and mental health. And health taxes we already discussed, and the ODA and DHA to play a catalytic role. And then to mobilize domestic revenues for health is challenging. It needs strong leadership, close interministry collaboration, and effective implementation of fiscal policies and public financial management system. And the last one was that most health systems are not well designed to provide preventive services, high quality longitudinal care, or financial protection for people with NCDs, mental health, and other chronic diseases. So we have to have a leverage mechanism to enhance continuity of care, avoid fragmentation service delivery, and reduce high out-of-pocket spending, and focus on primary health care. So that was it. Thank you.
Thank you so much. And before we proceed, I'd like to invite Dr. Athena Pappas, Chief of Cardiology and Director at Brown University Health Cardiovascular Institute. So two things that Dr. Mickelson said that I want to highlight, and I want you guys to think about what you got out of that lecture. But to me, the most important was it's a win-win situation, right? You can save lives and save money, and that's really what we need to think about. And the second point she made was she said the P word, politics, right? Something we've been dancing around this morning, but the point is if a butterfly flaps its wings in America, it affects people all over the world, right? And that's exactly what happens as a domino effect. So we're short on time. I want to give our panelists an opportunity to participate, and I want you guys to keep your answers short, under a minute if you can. But I'd like to start with you, Hyvel. You're the patient on this panel. If you could give us your perspective about your struggles, because that's what we're here at the end of the day, is to help patients as a heart disease survivor and also somebody who deals with type 2 diabetes.
Thank you for that question, and it's so imperative and important that a patient's voice is here, so I really applaud everyone for that. Because at the end of the day, we all want to come home. And I would tell you, my struggle, it started with type 2 diabetes. And then I had a stroke first, a heart attack, a second heart attack, quadruple bypass, and I have 10 stents inside of me. So if we break that all down to see what happened, a chronic illness doesn't just happen. It's not a single event. It's an everyday event. And we know all the variables, but that one controllable thing is the patient. Now, how do we address the patient's need when it comes to financial matters and the burden that happens? In my case, there were many days that there were medications that I couldn't afford. I had to push back in order to pay rent. So the entire family suffers because there's medical bills. You know, there's PCP, there's cost of prescription. I thank God for the American Diabetes Association with the fact of insulin was a major issue. And we know if patients are adherent to their medications, they can live longer and have a better quality of life. Knowing what I know about type 2 diabetes and how it is related to everything, the fact of a lot of stuff can be avoided. And this is something that has to go, put your money where your mouth is. And the politicians need to know this. If we can take care and understand the mitigating factors of the patient, not from the doctor, but the patient's perspective, because at the end of the day, they go home and the struggles of life hit them. And the mere fact of, yes, a doctor is there, but how do they deal internally to navigate a system they don't understand and still have to live a life with a family? Because we know when something happens, it's not a single person. It's a silo effect where the entire family suffers. Now, how do we address and take care of that patient's need? I'm grateful that I'm here, bringing that perspective, and there's a lot that needs to be changed. I know a Global Heart Hub is doing a lot for patient engagement and giving voices to the voiceless as far as information. But I feel it starts with the patient's perspective and understanding the burden and how do we alleviate that burden to effectively change and prevent a catastrophic illness from even becoming worse.
Give a voice to the voiceless. Wow. So powerful. I mean, you heard it from the patient herself. Give a voice to the voiceless. And that's what we're all here to do today. So with that, thank you for sharing that so much. With that, Joe, I'd like to go to you. You're a health economist. how did we get here, and where do we go from here? How are we looking at such an unbearable cost of care when we have patients like this sitting in front of us suffering every day?
Yeah, and thanks, and it was really important to share what you did, because I think part of the problem has been, part of the problem is policy design, right? And oftentimes, and Bente pointed to this also, this idea of comorbidity means that we have to really talk about a patient-centered rather than a disease-centered approach, because in a sense, with something like financial protection against catastrophic expenditures for individuals and families, in a way it doesn't matter if you become poor from TB or cardiovascular disease or whatever we care about, you don't become poor, right? So there's a design issue there. I think one part of the problem in terms of how we got there, and this is really in many countries, is that in a sense, the way we used to think about health financing and financial protection, and if you think of this kind of as any type of insurance, right, is that everybody's putting money in, and then when something unexpected and sudden happens, then you can direct the resources. You suddenly have a fire at home or something else. And chronic disease isn't like that, right? So this is the point, that we're not talking, and the data we have globally shows that a lot of the expenditures that are coming out of pocket are coming from medicines, okay? And these are not unanticipated issues. So the issue is how to deal with, in a sense, predictable long-term expenditures. One way, and colleagues who have worked on this say that if you're going to have, as many countries do, have co-payments that exist, they have to not be defined in percentage terms, right? So if you define your co-payment as like, the system pays 80%, you pay 20%, well, 20% of a lot is a lot, right? So what has worked better, and we've seen this in European countries where this has been done, for those countries that have either fixed, flat, and relatively low co-pays, it does two things. It makes it predictable, because the idea of using price, in a way, a market signal, to influence behavior doesn't work if nobody knows what the price is, right? So in that sense, the idea of a fixed flat copayment, I know that if I'm going, I will have this much, and there's an annual cap. And also, as Bente was talking about, differentiating by, to the extent that you can, by patient vulnerability, right? So for lower income people having a more exemption, for example. But it's harder in countries where administrative capacity is less to do this kind of individualized targeting. So the idea of simply doing something simpler, which is this fixed flat amount, is a better design in terms of trying to deal with this problem. And the overall message is really to take a person-centered rather than a disease-centered approach to these financing measures as well.
I love that. Thank you. I mean, cost transparency. You walk into Starbucks, you know exactly what you're paying for your cup of coffee. But you walk into a hospital, you're left with surprise medical bills, and then it disincentivizes you from seeking care again.
Yeah, in a way, that uncertainty is itself a cost.
Exactly,
right?
exactly. So, John, you're the past president of the ACC. I want you to put on your community hat as well as your health system hat and say, okay, can we actually adopt a model like Joe is saying? What can health systems do to try to make patients like Havel not have to decide between rent and medications and have strokes and bypass surgeries and stents?
Well, thank you for the question. It's interesting. 2 weeks ago in Los Angeles, we had the 2025 Global Conference of the Milken Institute, and this topic, no surprise, was a major discussion point. And Dr. Mehmet Oz made the point that we need to bend the cost curve because in the United States, 21% of our gross domestic product goes towards health care. And one of the topics of the plenary sessions was catalyzing the next era of healthcare in service of a healthier tomorrow. But the most well-attended session was entitled Shifting the Paradigm for Healthcare, Bending the Cost Curve, Understanding the GLP-1 Era. And this opened up a whole degree of discussion. So there was a presentation by ION, the insurance company, that provides healthcare benefit analysis to 50 million individuals that are employed across the world. And they looked at their database of that 50 million, and they asked the question, how many were on GLP inhibitors over a 2-year period, and what was the cost and what was the outcome. And what they showed in the beginning, this is a private company investigating their own database, so no bias. They found that in the beginning the costs were higher, but at 24 months, an extraordinary finding was that the cost became less, outcomes improved, and the average age they were talking about were women. 65% were women, 47 years of age. And the other convergence was a report by another pharmaceutical company about a non-peptide GLP inhibitor, simple to mass produce on scale, that theoretically could be distributed to low and middle income countries at a significant reduction in cost with improved outcomes. So that's a pharmaceutical innovation. With regards to health systems, I think at the end of the day, it's about knowing who you're dealing with and knowing your community. There's an interesting quote: if you don't know who you're dealing with, you have to go to the source. You have to talk to the patient. So in my institution, I had the privilege of working with Ron Victor, and Ron Victor did the Texas barbershop study and the Los Angeles barbershop study, which reached out to patients through the point of contact for many Black Americans, males. The point of contact turned out to be, the best point of contact was the church or the barbershop. And with the help of a pharmacist-assisted intervention, showed a significant improvement in quality outcomes for hypertension. And again, the problem with communication is the illusion that has occurred. And you cannot assume that with all the educational materials that are produced, that material gets down to the patient level. And I think there are patient advocacy groups across the world that are trying to address this challenge. And I think it's critically important to hear the patient voice.
I love the idea of bringing the medicine to the patient, because patients already have so much on their plate. Their health literacy is a barrier, their finances are a barrier, and so to actually go to the barbershop, go to their church, take the medicine to them, that's brilliant. Athena, I want to come to you next, because John talked about GLPs, which are sort of an interesting class of medications because they're both preventive and treatment. So I want to ask you a couple of questions. The first is, do you think we should focus our efforts more on prevention or treatment when it comes to reducing the financial burden of cardiovascular disease? And second, what do you think we can do as clinicians, as physicians, as well as patients to help kind of reduce this burden?
Thank you for the question, and I think the discussion here is really pretty robust. And I don't think it becomes tough to break it into an either-or proposition. I think, as we all know, one of the most important things is to focus on prevention, and I think we heard earlier about primordial prevention, and to focus also, quite importantly, I think, on some of the novel paradigms that we heard earlier from Dr. Jafar, for example, where we've really particularly for women and in communities, accelerated some of that work so that there's prevention happening at a community level that's understandable for that community. That's going to be the most effective, and I think we've heard from others the same thing. On the treatment side, it has to be accessible and has to be affordable and has to be understandable. And I think as clinicians, it's our job to touch on each of those, and then to just end with some of the pieces about the social determinants of health, because as we know, over 80% of healthcare is determined by that. As clinicians, we touch on 20% of that. I think we need to recognize that, and then in our advocacy efforts, work very hard on the social determinants of health, because it is that cycle of literacy, particularly around women, around making sure that there's pay equity, literacy, empowerment, and access. So I think it's not a dichotomous choice. It's the affordable care that we need to look at, and we heard a little bit also, I think, about some of the innovations, both from an economic standpoint, but whether it's digital health, remote access, I think those things will extend our reach as clinicians and allow us to do both prevention and treatment.
I love it. There's so much there to unpack that you just touched upon. I'll just highlight a few things. The first is, I was actually called into my boss's office when I worked for the hospital, and he said, stop treating people's LDL because you're preventing too many heart attacks, and we have to keep the lights on. And so there's this tension between the hospital systems and the physicians where, prevention doesn't pay. So really what we have to struggle with is the question of how do we make prevention sexy to the doctors, to the patients, but how do we make it financially lucrative? And that's where, to the point that Joe made, is that, you're losing the forest for the trees, because you may be getting more MI admissions today as a hospital, but you're actually spending more on healthcare and lowering your reimbursements in the long term. And if you actually kept people out of the hospital, your pie would get bigger, even though the piece of the pie for every patient might be a little bit smaller. So I think we have a lot to unpack there. You did talk about digital health, which I'll come back to in a second, but I want to go to Lillian and ask you to comment about Kenya, because it's got, universal health coverage, and we were talking over lunch, in fact, that you can have a universal health coverage model. Does that help? Or if you're waiting in line for months, does it actually make things worse? So give us a little bit of a perspective in this low middle income country of kind of what the challenges are there.
Thanks so much, and I'm honored to be part of this panel discussion. I think for me, I wish you asked me the question about prevention or treatment. I would obviously say prevention. I think prevention is the main way we're going to achieve financial protection, both at individual level and country level.
We'll make you the CEO of the hospital.
Yeah, because we know 80% of CVDs are preventable by addressing not just behavioral, but the other physiological risk factors, hypertension, diabetes, dyslipidemia. So I'll talk a bit about what we've done in Kenya. So at the population level, we've had quite a strong tobacco control policy. I think we've had it since 2007. So both looking at taxation, but also restricting access, to young people, controlling public smoking, warning signs and all that. And I was actually happy to see that the prevalence of tobacco use has gone down from 12 to 9%. That's from 2014 to 2022. So you can see our prevalence of tobacco use has gone down. I'm not sure if as a country we've actually costed the savings that have come both in lives and financial. And I think that's something I look up for. But clearly, that's showing you that we have achieved some form of financial protection, both to the people and at the country level. We are still lagging behind in terms of alcohol and sugar-sweetened beverages, although there is some work there. But I think for us as a country, that should be one of the key areas of focus in terms of achieving financial protection. But if you go to the individual level prevention, and this is looking at how we manage hypertension, diabetes, dyslipidemia. So we do have a universal health policy, universal UHC policy. We've had it for, I think, going to 2 years now. It has its own, challenges. But I would say that our benefit package has catered for hypertension, diabetes, and cardiovascular diseases. We have treatment guidelines. Medications are availed at the primary healthcare level, but the challenges are, of course, a weak primary healthcare infrastructure. So for example, the access to medication is not consistent. There are shortages of drugs. Sometimes the health professionals are may not have the capacity. They need training. And even with the UHC movement, we've had an increase in contribution. So we've had to increase the contributions that we are giving as citizens, and that sometimes can be a challenge for some people. So because for you to have a package that covers everything, it means you have to increase contributions. So that has been a bit of a challenge. And just to my last point, because again, you can't cover everything. Sometimes the amount allocated to cover some of these chronic illnesses is small. So for example, if you have multimorbidity, if you have hypertension, diabetes, dyslipidemia, sometimes heart failure, whatever is allocated in the UHC package cannot fully cover what you need. So in terms of multimorbidity, there is a challenge in terms of them getting the care that they need under the UHC policy.
Very much so, and obviously the frequent flyers will get more attention than a lot of the primordial prevention. So, I mean, there's just so much to discuss here, but I want to be mindful of time. I would ask each of the panelists to give a 30-second key takeaway for something we can do today to reduce the economic burden of cardiovascular disease. And whether you're speaking from a health economist perspective, a clinician's perspective, or a patient's perspective, what do you want people to take away from here? Hyvel, I'll start with you.
My takeaway, or what I want to convey, is nothing can happen that's for us without us. And that's imperative that we take
Well
that
said.
home. Because we matter, and like I said, we want to go home. And once we show the politics of everything and understanding the patient's burden, I think that has not been explored at all. But I think that's avenue for a lot of exploration, but definitely change to occur.
Thank you for bringing that perspective. Athena?
Sure. Thank you. So tough for 30 seconds. I would say two big points. One, advocacy. So as clinicians and as people, and we heard about politicians being so important, we all vote, hopefully. And so using our advocacy is incredibly important. So, and getting the word out about some of the goals of WHF and the UN are goals coming forward for reducing NCDs. I think the second really important piece is team-based care, things that will be important if we're thinking about economics. Physicians have a limited amount of time. There's community-based healthcare workers, there's nurses, and it's that reach that's going to be the most impactful. So I think the two together will be most important.
And earlier you had said technology and digital health. I would echo that as well. John?
Yeah, so I'd say policy and systemic changes. We need to prioritize primary prevention, has been said, but we need to invest in primary prevention programs that target high-risk groups in particular, where they can have a greater impact. We also need to integrate care, which is what Athena said, primary care, specialist care, and community-based services together that can improve coordination and outcomes. And then the final piece is monitoring evaluation. Without data, you cannot act, and you need to show policymakers that you're having improved quality, you're bending the cost curve, and you're having quality outcomes. Okay.
So you're saying the left hand needs to talk to the right.
Exactly.
I would say focus on primary prevention, both at population and individual level.
I can't be that fast. But I mean, one of the messages from what I was hearing and following up on something that Benta said was around this word innovation, and part of it, and John had given this example of the barbershop, is that the best thing that financing can do to support innovation and delivery is to be as simple as possible. So the idea that you want all kinds of fragmentation and so on is a problem. We've seen in countries, a very good study from Mexico, where you, for example, part of the population has their insurance linked to employment and the rest doesn't, and people move in and out of employment, and that actually interrupts continuity of care. You lose your providers. One thing also I just wanted to comment on a lot of accents like my own here, is to ensure that people know the world is not like the US. Right? Especially when it comes to healthcare. Over 40% of the world's health spending occurs just in the US for about 4% of the world's population. A lot of that arises from its fragmentation, duplication, and I think what you said, Payar, that disease is more valuable than health to the health system, especially in a context of basically private return seeking capital on that. Okay, so that's not what the rest of the world wants in general, and they're trying to move towards more unified systems of care.
We need to make our money work smarter for us, not harder. And last comment before we close.
Great panel. I would add two things. I think person-centered and country-focused and owned. It's very important.
Well, thank you all. I hope we've left you uplifted, thinking about your credit card bills, but also thinking about the health system and how we can help patients like Hyvel, get access to care, how we can change and transform cardiovascular disease, and how we can stop hemorrhaging money. 80% of cardiovascular disease is preventable, yet it's one of the biggest drivers of our healthcare system's costs. So thank you all for your attention. I want to thank the panel. Please give them a round of applause for their contributions.